Cases will be presented by Dr. Bali Ghosh and Dr. Kaustav Ghosh. So I will request the mentor to please pitch in and introduce your speaker. In the meantime, our president, Professor Kalpana Dhatto, has come. I will request her to give the welcome address.
Okay, thank you, Dr. Shapan. Very good evening to all of you, and welcome to this digital platform on Sandhya Pathshala. It is one of the series of Sandhya Pathshala. We are having since January in every month, and it is based on clinical examination and case-based orientation, bedside teaching. There will be no will limited the theoretical discussion, and will discuss more on the clinical basis. So I'll request the mentors and the experts, please concentrate on the clinical based approach to the case, so that it will be beneficial for the postgraduates. And I welcome all the experts, Professor Ostam Naik, Professor Supratim Datta has joined just now, and all other dignity faculties who have joined in the as a panel, and all the attendees. I will also welcome you all. Please, we'll start. I will request the mentor, Doctor. Now I can see the Pritam. I think Shubham has joined. No, Shubham has not joined. Costa, please call Shubham for joining, and I'll request Dr. Pritam, you start, huh?
Yes,
and Pritam is a DM in pediatric hemato-oncology from PGI Chandigarh, and he has passed MBBS from Medical College Kolkata, and now he is looking after the pediatric hematology oncology cases in SSKM as a visiting physician, no?
Yes,
consultant. Yes, okay. So in SSKM under the with the combined with the Professor Supratim Datta. So please, Dr. Pritam Singh Rai, please start introduce our presenter and start the case.
Thank you, ma'am, for the kind introduction. From SSKM today, our case will be child with interesting parotid swelling, and we will learn that how the case unfolds itself and surprises us at the end. So the presenter will be Dr. Bali Ghosh. She is a second-year postgraduate student in pediatrics at SSKM Hospital. Bali, I think you can start sharing your screen. Over.
Thank you, sir, for your introduction. Good evening, everyone. I'm Dr. Purvali Ghosh, and I'm going to present a case on hemato-oncology today evening. So we had this patient. We had this 5-year-old boy, Master R, who was a resident of Howrah and was admitted on 6th of May to our hospital. He presented with a complaint of multiple swelling in neck, armpits, and groin since last 2.5 months. The swelling started as 2 small swellings under the chin, approximately the size of peas. It was gradually progressive in size, increased up to the size of almonds over a period of 1.5 months. New swelling started appearing in the area below the ear lobule, which was also gradually increasing in size. Further swelling started appearing in the armpits, posterior part of the neck, chest, and inguinal region within a span of next 1 month, and it was associated with bilateral redness of eyes. There is no history of fever, non-purulent conjunctivitis, mucosal changes, periungual peeling, edema of distal limbs, generalized rash, joint pain, drug intake, any localized pain, skin changes over the swelling, contact with tuberculosis patient, cough, weight loss, recurrent infections, fatigue, bleeding manifestations, or any history of blood transfusion. The patient was treated conservatively with no resolution of symptom. On the contrary, the number of swellings gradually increased in number. The patient was born out of non-consanguineous marriage with non-significant birth history. The feeding, immunization, and developmental milestones are age appropriate. There is no similar illness in any of the family members, and no one is suffering from any chronic disease. On examination, the patient is alert, conscious, cooperative, oriented to time, place, and person. There was no pallor, icterus, cyanosis, clubbing, and edema. The pulse rate was 100 per minute, regular, normovolumic, and all the peripheral pulses were equally palpable. The respiratory rate was 26 per minute, regular, and abdominothoracic in nature. And the patient was afebrile. The BP was 90/60, which was 50th to 90th percentile as per age. And the saturation was 99% in room air. Anthropometry showed height for age more than 97 percentile, weight for age between 50th to 70th percentile, 75th percentile, and BMI less than 3rd percentile. The patient had generalized lymphadenopathy with submental, submandibular, preauricular, and postauricular lymph nodes palpable. The upper, middle, and cervical lymph nodes were also palpable, the largest being 3 cm in diameter. The posterior cervical lymph nodes were palpable and was 1.5 centimeter in size. The bilateral axillary lymph nodes were 3 centimeter in size. The bilateral epitrochlear lymph nodes were also palpable. The inguinal nodes were palpable bilaterally with 3 centimeter each in size. The lymph nodes were firm, discrete in nature, with well-defined edges, non-tender, with no overlying skin changes, and no fixation with the underlying structures. On head-to-toe examination, there was swelling of bilateral parotid glands, which were 5 into 5 centimeter on each side, hard, non-indurated, sharp margins with no overlying skin changes. There was also bilateral scleral redness with perilimbal sparing. Systemic examination did not reveal any significant finding. So summarizing, we had this 5-year-old male child who presented with progressive generalized lymphadenopathy for 2.5 months, not responding to antibiotics, bilateral painless parotid swelling with no other complications, cervical, axillary, inguinal, and epitrochlear lymph nodes, which were significantly enlarged. There no history of fever, recurrent infection, and blood transfusion. Also, there was no pallor, overlying skin changes, or organomegaly. So now coming to the differential diagnosis.
Stop. Hello, Purvali.
Sir.
This is a clinical exercise. So that's why coming to your history. This is a 5-year-old male child with history of generalized nodular swelling in the cervical region, in the axilla as well as in the groin of 2 months duration.
Yes, sir.
And there is no history of fever, bleeding manifestation, or pallor needing blood transfusion. Neither there is any family history of any cause.
No, sir.
I mean, exposure to tuberculosis.
No, sir.
So if this is the history, coming to the history from the history point of view, what are the possibilities that you kept in your mind?
So the possibilities would be chronic diseases like presenting with generalized lymphadenopathy. Like first would be there is a possibility of tuberculosis, though there are negative history. But
this is a case of from the history. This is a case of generalized lymphadenopathy. Apparently, there are generalized lymphadenopathy from the history.
Yes,
No
sir.
history of fever, bleeding manifestation, or pallor needing blood transfusion. No history of exposure to tuberculosis in the family. No history of similar lesion in the family, similar illness in the family from the history. So likely this is a case of generalized lymphadenopathy. So generalized lymphadenopathy in a 5-year-old male child, what are the common possibilities? From the history, we can deduce this much, not more than that.
Before that, Suprasimda, I want to ask one thing. Was there any history of bony pain or tenderness? Bone tenderness was there?
No, sir. No, sir.
No bony tenderness?
No.
And axillary, generalized axillary or any particular group was involved in axilla?
Sir, in axilla, mainly the central group of lymph nodes were involved. Others were also enlarged, but significantly the central group of lymph node was enlarged.
Yes. So bony tenderness was not there?
No, sir.
Yes. Next, we will continue.
Okay, so again back to the same question from the history. If it is generalized lymphadenopathy, what are the common causes of generalized lymphadenopathy in a 5-year child?
Sir, it can be infectious diseases which it can be a case of scrub typhus.
Infection like the specific infection?
Infectious mononucleosis.
Viral infection. Viral infection.
Have you examined the throat? Throat was clear or tonsils were... What is the finding of examination of the throat, tonsils?
So tonsillar, there was no tonsillar enlargement. Only the lymph nodes were palpable. There was also there is no history of any sore throat.
Right.
So now, other than the infection, the one is the viral, another is the
Viral is a 2 months history. History was of 2 months.
HIV infection.
Sir, HIV can be a possibility. HIV can be a possibility. Epstein-Barr virus can be a possibility. Then infectious mononucleosis.
Pallor was not there, right?
No, sir, pallor was not there.
Suffering from 2 months, but there is still no
tuberculosis, another infection, generalized lymphadenopathy in tuberculosis.
Yes, sir, tuberculosis is another possibility.
What is the chest finding?
So the chest, there was no, sir, there was no any significant, there was no like bilaterally vesicular breath sound was heard. There was no.
This is a case of generalized lymphadenopathy. Did you try to exclude the clinical presence of mediastinal and lymph node enlargement? And how this is detected, mediastinal lymphadenopathy clinically?
And also abdominal lymph node also.
Sir, on direct percussion on the sternum can reveal if there is a dull sound, it can...
Which intercostal space the percussion is to be done?
So second.
Second from right to left, not over directly. You have to proceed from right side to left side on the second space. Abdominal lymph node, periaortic, paraortic, have you palpated?
Sir, abdominal lymph node, on palpation, I couldn't elicit any significant swelling in the...
Yes, that is a method of palpation of the abdominal lymph nodes also.
Yes, sir.
And patient is suffering from 2 months, but there is no loss of weight or any other, no evidence of malnutrition.
No.
2 months, having 2 months history.
Yes, sir. So there was there was no any no signs of any systemic features. There was no constitutional symptoms like fever. He had just presented with generalized lymphadenopathy. And
so go back to your anthropometric data, Purvali.
So the weight.
BMI is less. Height and weight are.
The height is 155 centimeter. The 5-year-old child. It seems there must be some mistake. It's too high.
Yes.
155 centimeter, almost like an adult. So there must be some mistake. And the BMI is
18 kg. Weight also 18 kg.
BMI is 6.08. This is too low. But the photograph of the patient, it's not looking so. There may be some mistake.
Yes.
Okay, so this is a case of generalized lymphadenopathy. The anthropometric data are showing some bizarre, the bizarre figures are showing over here. Very difficult to say something from this anthropometric data.
BMI is very low. So,
BMI is very low because I think your height plotting is not the proper. The 155 centimeter, it's too high for a 5-year-old child. So that's why the BMI is showing very short value, the low value. Okay, come to this is a case of generalized lymphadenopathy with epitrochlear lymph. And when you say clinically that there is generalized lymphadenopathy, when the clinicians say that there is generalized lymphadenopathy.
So generalized lymphadenopathy, if there is if there are more than 2 groups of lymph nodes are
non-contiguous area of lymph node involvement. More than 2 non-contiguous area of lymph node.
Where cervical lymph node.
All lymph nodes are palpable, including the epitrochlear lymph node. Supraclavicular group of lymph node.
So supraclavicular was not palpable, sir.
Just
All right.
remember one thing, supraclavicular lymph node, always, the size doesn't matter. This is always pathological.
Significant.
Yes.
Even a small size of supraclavicular lymph node indicates some pathology. And usually this is because of the malignancy, usually. And sometimes it could be tubercular origin, but this is usually malignancy. Coming to the, again, general lymphadenopathy causes, the one is the infective cause, viral, ABV virus, the HIV virus, and coming to the tuberculosis, this is another infection. Coming to the non-infective cause, what are the non-infective causes of generalized lymphadenopathy?
So
Common.
non-infective causes can be one can be malignancy. Then
What malignancy? What malignancy?
Malignancy like
malignancy like lymphoma or leukemia.
both acute leukemia and lymphoma.
Yes, sir.
Both can give rise to generalized lymphadenopathy. Any other the malignancy or non-infective cause?
Non-infective cause like even in autoimmune condition, rheumatological conditions like in JIA, systemic JIA, it can
Yes.
be, there can be generalized lymphadenopathy. Then
Autoimmune lymphoproliferative disorders also possible.
What about LCH? LCH, lymphocytic histiocytosis. What about LCH?
so,
This is another common situation. LCH, generalized lymphadenopathy.
Langerhans histiocytosis.
Even in SLE also sometimes, although this is not the age for SLE, 5 years old male child, SLE and GIA both can give rise to generalized lymphadenopathy.
That most of those cases, hepatosplenomegaly will be there. May it be leukemia, may it be lymphoma, may it be GIA, may it be LCH, all cases.
Now, from the history and the examination, what possibilities you should keep? 1, 2, 3, priority wise?
So priority wise, one would be first I can keep tuberculosis as a differential because
tuberculosis. Why? What are the points in favor and points against?
So general points in favor will be generalized lymphadenopathy, and second point would be TB is endemic in India. That is another possibility. However, the points against are there is no history of any low-grade fever. There is no history of any contact with TB patient. There is no history of weight loss or cough or hemoptysis.
Another important point, lymph nodes are discrete, not matted.
They are not matted.
In tuberculosis, most of the cases we will get matting of the lymph nodes.
Matted lymph nodes.
But here all the lymph nodes are discrete.
Discrete.
So that is going against.
What about parotid swelling?
So
Do they occur in tuberculosis?
Sir, not likely. Parotid swelling can occur. There is literature like if there is TB of parotid gland, then it can occur as bilateral
very rare.
Rather, it is more common in LCH. Parotid involvement may occur in LCH.
If the expert can give me permission, I can comment one thing over here.
Yes, ma'am.
Yeah, actually, parotid, if the parotid is here, that is the characteristic of HIV, stage 2.
Yes, yes.
So you keep in mind when this parotid gland is involved, could it be HIV? Okay.
Yes.
Okay, thank you.
Usually, bilateral enlargement of parotid gland, it's not a feature of the tuberculosis. So it's saying that it is something else. It could be other infection or it could be malignancy. Parotid gland enlargement can be found in acute leukemia. It's not that common in lymphoma. That is why, so from the history and from the examination, the possibilities, of course, the tuberculosis is common in our country, you can keep, but the side by side, the HIV possibility as well as the malignancy possibility to be kept in mind.
Next, continue.
The characteristic of lymphoma, one is the fever, another is the night sweat, another is the weight loss. So I didn't see that you mention all those things in your history.
Sir, in negative
Fever,
history,
weight loss and night sweats.
If it is a
negative history, fever, weight loss, or
and night sweats. These are the
night
three
sweats.
features of
If
lymphoma.
in A, it may be these features may be absent also.
Another thing, the redness of the conjunctiva you mentioned,
Yes, sir.
but on examination you never said anything about the eye changes over here. So what about that? Is it the only mere history, or there was a sign in the eye examination also?
Sir, there was no only on there was a history of eye change. There was a history of bilateral redness of the sclera, and on examination also the patient had redness in the eyes with perilimbal.
Purulent or non-purulent?
So non-purulent.
And persisting for 2 months or short history.
Yes, as per history, it was persisting, and upon examination, it was there, and it has been persisting.
Yes.
Persisting. So
Persisting.
you on examination also there was redness of the conjunctival redness was there.
Yes, sir.
What is that? Is it conjunctivitis or scleritis or something else?
Sir, it is probably scleritis, or like it can be of infectious origin, or because of his underlying malignancy.
Scleritis, there are tender.
In tuberculosis, which conjunctival the changes sometimes we get? In
It's got
children,
plictenular conjunctivitis,
plictenular conjunctivitis.
The primary complex allergic manifestation.
Or probably it can be because of the congestion, scleral congestion, the redness.
So after tuberculosis, what are you thinking?
Sir, HIV can be a possibility.
Possibility, yes. But again, there is no evidence of any loss of weight or other things.
No.
Only lymphadenopathy.
Only lymphadenopathy. Generalized lymphadenopathy and bilateral parotid swelling. Painless parotid swelling.
So maybe.
Okay, Dr. Costa, we can proceed further, huh?
Yes.
Yeah. Okay, proceed.
So after these were my differential diagnosis initially. Mumps was the first because of the bilateral parotid swelling, but the most important point against it was that it was painless, and there was absence of fever, and also vaccination was up to date. TB was another differential diagnosis because of the generalized lymphadenopathy.
Probably you should skip this slide because mumps is not a possibility over here. Why did you keep mumps? I don't know. You already discussed about the differential diagnosis from the history and the finding, tuberculosis, HIV, and the malignancy.
Yes, sir.
And of course, the LCH should come in the differential diagnosis. But the parotid swelling, presence of parotid swelling, they indicate that it could be either HIV or malignancy. That we already discussed. So there is no question of mumps over here. Sarcoidosis regarding this is very, very rare in pediatric age group.
Yes, sir.
Very, very rare. So that is why the sarcoidosis, the thing is there, very, very rare. Very rare. What Kostov says, I don't know, but I have not seen any confirmed case of sarcoidosis in pediatric age group till date. Even
Rare, but seen 1 or 2 cases, but
mumps is a far up possibility over here. We should not keep the mumps, and you kept it in the number 1 position. So better to skip mumps from here from the differential diagnosis. Okay, proceed.
So now moving on to the investigation, we had done the first investigation was complete blood count with peripheral blood smear, which was normal. There was no significant abnormality that was seen. The peripheral blood smear showed predominantly normochromic normocytic with adequate platelet count. Blood biochemistry showed normal serum bilirubin, liver function test, liver enzymes, urea creatinine, and sodium electrolytes were also normal. However, serum uric acid, serum inorganic phosphate, and LDH was on the higher side. Chest X-ray showed superior mediastinal lymphadenopathy. HIV serology was non-reactive and MANTU was also negative. So from investigations, since MANTU was negative, DLCB-NAT was negative, and chest X-ray did not have any typical features of tuberculosis, tuberculosis was ruled out. And since HIV serology was negative, HIV was also ruled out.
Now, one thing, the tuberculosis cannot be ruled out based on the MANTU negativity and the GLCB-NAT negativity. It's very difficult to say. Very difficult to say.
Sir, but history is also, there's no...
You can keep that tuberculosis is a less possibility. That you can say.
Less possibility.
But they ruled out this is not the correct term. Okay, carry on then.
So now, is it a case of acute leukemia? Because we had generalized lymphadenopathy, high uric acid, high LDH, and high alkaline phosphatase, along with painless bilateral.
High alkaline phosphatase? Alkaline phosphatase was high.
Sir, it was...
phosphate was high.
Sorry, inorganic phosphate.
Phosphate.
Inorganic phosphate was high. Alkaline phosphate.
Alkaline phosphatase high indicates something. The bone
Bone
involvement.
turnover. Bone involvement.
High phosphate level is high. Uric acid is high. LDH high. Generalized lymphadenopathy. Bilateral parotid swelling.
What is the total count?
The total count was 7,000.
So mostly, maybe.
Mostly lymphocyte.
The peripheral blood picture is normal. Even the hemoglobin is normal and the platelet is normal.
Yes, sir.
Everything
Whereas you did investigation in the line of tumor lysis syndrome. There the inorganic phosphate level is high, uric acid is high. And LDH, this is a sign
what
of
was the calcium? Normal.
Calcium is normal. Calcium is normal. 10.3.
Potassium?
Potassium 4.7 normal.
That is also normal. Potassium should be high. Calcium high, phosphate, calcium low, phosphate high, uric acid high. So
the
maybe
possibility of malignancy.
There is a possibility. There was a possibility of malignancy because
malignancy, but there is no pallor, no other bony tenderness, no hepatosplenomegaly. All
No,
are
sir.
going against.
Yes.
Okay,
So
in acute leukemia, what are the typical blood changes that you can expect? Peripheral blood changes in acute leukemia. Acute lymphoblastic.
Acute lymphoblastic leukemia, first there can be anemia, bicytopenia or pancytopenia. Mainly their WBC count.
Monocytopenia. Remember, monocytopenia is very, very rare. If the child shows the feature of monocytopenia, either the anemia or the thrombocytopenia, the other two elements are normal. So the chance of acute leukemia is very, very rare over here. So bicytopenia or pancytopenia could be. So of the bicytopenia, that means the low hemoglobin level and the thrombocytopenia, which comes early?
So first thrombocytopenia will be coming
Why
early.
thrombocytopenia comes early?
So because relatively platelet lifespan of platelet is
only 10
7
days. Lifespan platelet 10 days only, or whereas in RBC this is
RBC is 120 days.
So that's why the thrombocytopenia occurs early.
Yes.
PBS doesn't show this type of change.
Sometimes there could be leukoerythroblastic blood picture. The presence of immature RBC and presence of immature WBC series in the peripheral blood, leukoerythroblastic blood picture. It can happen in any bone marrow infiltrative disorder.
Yes, sir.
Was there any blast cell or not?
There was no blast cell and there was no peripheral blast cell.
So even if you think it is leukemic leukemia.
Yes, sir. Because there are no changes in the peripheral blood smear, it can be.
So for that you have to do bone marrow aspiration.
Bone marrow.
Next, what other investigation you did?
Sir, since in the blood biochemistry there was an indication for the uric acid, the inorganic phosphate, and LDH hemolysis were a bit on the higher side, and we had a high suspicion of leukemia. We went for bone marrow aspiration and biopsy. instead of lymph node biopsy because
Before the bone marrow examination, so yeah, at the same time, the chest X-ray showing me the mediastinal lymphadenopathy also.
mediastinal lymphadenopathy.
So the investigation till now, the no changes in the peripheral blood. The tumor lysis, one or two of the tumor lysis markers are elevated. LDH is elevated, and there is mediastinal lymphadenopathy. They suggest the malignancy. So in which malignancy, the mediastinal in pediatric cases, pediatric malignancy, the mediastinal lymphadenopathy is common.
Sir,
Which
in,
malignancy?
more common in lymphoma and non-Hodgkin lymphoma, it is more common.
And also in T-cell leukemia.
Non-Hodgkin. In acute leukemia, the acute
T-cell.
lymphoblastic leukemia, which type commonly
And, in
associated
acute
with
leukemia,
mediastinal
TLL, in
T-cell,
TLL, it is more common.
T-cell ALL. So T-cell ALL is commonly associated with mediastinal lymphadenopathy. What are the other characteristic, clinical characteristic of T-cell ALL? Two other characteristic. One is the male child. It commonly affects the male boy more than 8 years. Boy more than 8 years. One. Second is the mediastinal lymphadenopathy, and third is the high WBC count. More than 50,000 WBC in the peripheral blood. So these are the three characteristics of T-cell ALL. So one is present and two are not present.
One not present.
But bone marrow aspiration 80% blast.
Bone marrow aspiration. Now come to the bone marrow.
Now, bone marrow aspiration revealed 80% blasts with atypical mitosis. Immunophenotyping was done from bone marrow sample. It showed 83% of abnormal blasts and the expression of B cell antigen, namely CD33, CD10, CD19, CD22, and CD79A positivity. Cytogenetics was required in this case for prognostication, but it could not be done because of the financial constraints. So
CD33 for B cell. 33?
Sir, immature B cells.
1922 all are for B cell, but
B cell.
33
33
not for B cell, I think.
T cell. 33 T cell.
Sometimes aberrant expression can occur with myeloid marker also. In
Yes,
ALL.
that is called acute mixed lineage leukemia. There is a possibility, one or two marker of T cell along with other B cell marker. That is acute mixed lineage leukemia. Mentor can tell this well.
So, sir, with as Dr. Shrupadin Datta sir was mentioning, it is most likely to be aberrant myeloid expression of CD33, which is the myeloid marker. When it is mixed lineage leukemia, then we get other myeloid marker like CD14, CD64, or non-specific esterase, etc. And MPO positivity is mandatory. So just having CD33 positivity will not indicate it to be mixed lineage leukemia. Most likely, it is nothing but a aberrant expression of myeloid marker.
Yes. So next.
Sir, so this is the bone marrow. This is a picture of bone marrow aspiration, which is showing lymphoblasts. And here is the report of the bone marrow biopsy, where bone marrow has been infiltrated completely with blasts, as shown in the image. And here is the immune phenotyping report, which is showing CD10, CD19, CD22, CD34, and 38 positivity. Also CD79A positivity. So the final diagnosis in this case was a precursor B-cell acute lymphoblastic leukemia, which presented as a bilateral painless parotrydomegaly and generalized lymphadenopathy.
So, Purvali, coming to the bone marrow.
Yes,
To the
sir.
bone marrow. In acute leukemia, bone marrow aspiration and bone marrow biopsy, both are required only bone marrow aspiration is sufficient.
The bone marrow aspiration would be sufficient if there are more amount of blast cells, and even from the aspirate sample we can do the immunophenotyping. So bone marrow aspiration would be sufficient.
Why then the biopsy is also required simultaneously? So if the aspiration is sufficient, because technically the biopsy is more difficult.
Sir, If aspiration is being done, there can be areas where the blasts has not infiltrated, so there can come as false
There
negative.
could be focal infiltration of bone marrow with leukemic blast cells. So aspiration can miss it. So that's why both are required. Both bone marrow aspiration as well as the bone marrow biopsy, both are required. And immunophenotypically, the B cell ALL, either the B cell ALL or the T cell ALL. Do you know the percentage of B cell ALL overall? What percentage of the
It is
total
B cell
leukemia is constituted by B cell ALL?
Before that, 1 point Puvali, whether mature B, pre-B or pro-B.
Mature B cell is very rare. But B cell ALL,
Sir, this is a pre-B cell because the immature antigens are also.
Why? CD10.
CD10 is present also.
That indicates
The mature are 19 and 20. Those are the mature markers. CD10 is common for all the B cell.
So what here? What is it, the type? Mature or pre or pro?
Sir, pre-B cell.
Pre-B cell. Because
the
it has
WHO recent classification, the pre-B and etc. The WHO has not mentioned all these things. Only the BALL, TALL.
No, it is prognostically related also.
Dr. Pritam can highlight over here.
Prognostically, what's prognosis?
Ask Pritam. Bolo, Pritam ke bolte ho.
Yes,
Can you
ma'am.
highlight the recent WHO classification on ALL?
Yeah, so sir, the recent WHO classification does not classify these as pre, pro, and the mature. These were all older classification terminologies. But as Dr. Kaustav was mentioning, it indeed has prognostic significance. So for the pro-BALL, which is CD10 negative, which has very bad prognosis because it is associated with translocation 411, mainly seen in the infant leukemias. And mature BALL, which is CD20 positive, is a totally different entity, which is basically a leukemic form of Burkitt lymphoma, which is called Burkitt leukemia, and it's been treated in a completely different way and not like ALL. So yes, those things are relevant clinically, but as far as WHO terminology goes, those terms are obsolete.
Another cytogenetics was done or not?
So cytogenetics was not done for this patient because of the financial constraints. It could not be.
What is the importance of cytogenetics, Purvali?
Sir, it helps in prognostication of the disease because there can be hyperdiploidy, Philadelphia chromosome, which was 922. 922, it has a.
So if 922 positive in ALL, prognosis good or bad?
Sir, it shows good prognosis.
In ALL,
no, it is
in
bad
ALL bad prognosis.
Bad prognosis.
922 shows bad prognosis. CML
so cytogenetics are also important.
411.
So
Bad
I have a
prognosis.
question to mentor. Mentor sir, so even if there is high amount of blast cell in the bone marrow, why the peripheral blood picture is showing nothing? Even no hepatosplenomegaly, no bony tenderness, no platelet low, everything is low, even if there is 80% blast cell. Is there any reason?
Can't be sure, sir. Very difficult to say. Not sure whether he has received any prior dose of steroid. I'm just kind of thinking aloud. Might have received a dose of 1 or 2 doses of steroid outside, which might have, just washed away the peripheral blood blasts. But yes, we intermittently do see a leukemic leukemia when your marrow is filled with blast and it's not been spilled over into the blood. Maybe because of marked myelofibrosis, that can sometimes happen.
Yes.
But can't be sure.
Thank you. So can I move to next case, Supatendra?
No. The many things are there. 1 hour time for each case, na? So many.
1 hour, then continue.
1 hour time. So 10-15 minutes are there for Purvali. Purvali, let's have interaction about this case. The thing is that the already Pritam told that why there is no lymphadenopathy, hepatosplenomegaly, probably the leukemic blast didn't infiltrate into the periphery from the bone marrow because of the possible reason of myelofibrosis. Okay, so the what is the typical bone marrow changes morphologically in ALL? If you the histological description of a bone marrow.
Sir, in ALL, there will be the presence of there will be infiltrates with lymphoblast, which will be PAS positive and MPO negative in staining.
What is the percentage of blast in the bone marrow in ALL? What is the usual percentage when you say that the ALL is there?
You say what is the normal count and when you will tell leukemia.
Sir,
What
if
is the normal blast cell population in the bone marrow, and in ALL, what happens to the blast cell in the bone marrow?
Sir, in blast, according to WHO, if there is more than 25% of the blast cells are present, it shows it points towards leukemia.
What is the normal count? What is the normal count in bone marrow? What is the normal count of blast cell?
Normal, which is less than 5%.
Less than 5%.
Then what is 5 to 25? Then probably what is more than 5 up to 25?
Sir, it can be a leukemic leukemia or
No.
No.
Suppose 10%, then what you will say? Not above 25, but more than 5. Is there any condition where you can get this?
Ajay, I'm putting this problem before Dr. Pritam. In AML, more than 20% myeloblast in the bone marrow is suggestive of a diagnostic of AML, acute myelogenous leukemia. And in between 5 to 20%, we call it myelodysplasia. But in many cases of the suspected ALL, we get the blast cell population in the range of 10 to 12%, not crossing 25% limit. So what is the possible explanation, Pritam? Any?
Yeah, right, sir. So if there is such kind of blast percentage less than 25%, it could be leukemia in evolution. So we have to see immunophenotypically whether those blasts are carrying, leukemia specific immunophenotype, or they're just some blasts of non-specific regenerative marrow blasts. And moreover, if there is any cytogenetic aberration which is suggestive of leukemia, then whatever may be the blast percentage, it has to be taken as leukemia. Like let's say in case of ALL, you are getting a blast percentage of 15%, it is showing positivity for translocation 1221. Then you have to take it as ALL, even if your blast percentage is less than 25%.
Yes, but another condition, leukemic conversion of lymphoma. Suppose sometimes we have seen lymphoma, because the difference is very thin in lymphoma and leukemia. So in that case, is it possible to get between 5 to 25? Leukemic conversion of lymphoma.
Yeah, so when, out of all lymphomas, such kind of thing can happen only with lymphoblastic lymphoma.
Yes, lymphoblastic lymphoma.
Yeah. So yes, if a lymphoblastic lymphoma is infiltrating the marrow and transforming into ALL, then yes, kind of thing can happen. You can get a blast percentage somewhere between 5 to 25%.
Sir, can I say anything?
Yes.
Sir, this can also happen in Burkitt's because we often get patients with
that is Burkitt's, the B type of lymphoma.
Yes. Burkitt's leukemia, and in ALL, the cutoff is usually 20%, not the 25%. In FAB classification and the standard practice guideline for blast percentage in marrow is more than 20%, not than 25%. Obviously, there is a controversy whether 20 or 25 can be the cutoff, but the present cutoff we follow is 20%, not 25% in the bone marrow.
As mentioned by WHO, it is WHO.
I'm just interfering. Because time is only 5 to 10 minutes late, Dr. Pritam, in the meantime, you just go on taking the questions or suggestion from the chat box and keep on answering on that. Otherwise, you won't get the time.
So, Puvali, another question. So, most of the cases we used to get bony tenderness. Even we have seen JIA cases ultimately diagnosed as leukemia. So, why there is so much bony involvement? Bony tenderness and everything, we very frequently we get.
So
Is there
there
any
Sir, because the blast cells infiltrate because of bony infiltration, there will be bone involvement, and also the bones will be involved because of the high turnover.
No, that is not the reason. Because a bone has no nerve fiber. Until or unless there is periosteum is involved, there will be no tenderness, no pain. Any? Subperiosteal hemorrhage may occur that can stretch the periosteum and can cause pain. Bone infarction may occur. All these factors can lead to pain. All are related to very much high count. That can cause microvascular obstruction and ischemia and infarction and can lead to.
Yes, I completely agree. Probably, and I mean, all the PG student attending should remember bone pain in leukemia does not happen because of bone marrow infiltration.
Yes.
If that was the case, then all patients with thalassemia who have massive marrow hyperplasia will be having pain. That doesn't happen, no. So bone marrow doesn't have nerve fibers. The pain happens because of periosteal involvement by leukemia or infarct or hemorrhage subperiosteum, as Sir has mentioned already. There is a very common misconception among the PG students. So, as Dr. Datta has, Dr. Kalpana Datta ma'am has suggested, I will quickly take upon the comments and the questions in the chat box. So, there is a comment that epitrochlear lymph node involvement is most common in NHL. Okay, so I take that comment. However, I will like to mention that in pediatrics, most of the non-Hodgkin's lymphoma has extranodal presentation. Generalized lymphadenopathy, like it was there in our child, it's not a common presentation for childhood non-Hodgkin lymphoma. The most common childhood non-Hodgkin lymphoma is Burkitt lymphoma, which presents as abdominal mass or as a jaw mass. And the second most common non-Hodgkin's lymphoma in children is T lymphoblastic lymphoma, which presents as mediastinal mass with superior mediastinal syndrome. So generalized lymphadenopathy that we see in leukemia is not very common to happen with non-Hodgkin lymphoma, at least in children. And then there was a question that there was no cytopenia, so high-grade NHL may be a possibility. So I think that answers. What was the ESR and CRP? Probably, can you just go back by 2 or 3 slides and show what was the ESR and CRP? I think ESR value is not available.
Sir, ESR and CRP values are not available.
Were not available. Actually, to be very honest, this diffuse bilateral painless parotitomegaly from the very outset made us think only 2 conditions, HIV and leukemia, to be very honest. So once HIV serology was negative, we were clinically pretty much sure that it will turn out to be acute leukemia, and we went ahead with bone marrow examination. So there is another question that there was no cytopenia, so we had to do a lymph node excisional biopsy for HP and IHC, followed by marrow aspiration. So I think that answered the question. We did not think a possibility of lymphoma. This very prominent parotitomegaly bilaterally made us think leukemia and HIV only as a differential diagnosis at the very outset. Yeah, I think these were the questions. There is another last question. Can CD markers be done on peripheral blood? Yes, CD markers can definitely be done, but provided there is good amount of blast cells. And by saying good amount, it is arbitrary numbers. So typically they say if your blast count in the peripheral blood is crossing 10,000, that is a good sample that you can easily run flow cytometric IPT from your peripheral blood itself. Actually, we do it day in and day out whenever the TLC count is significantly high. It's very easily done when you did not do a bone marrow. Over from my end. Thank you.
Okay, thank you very much. Just before we stop discussion about this case, the Purvali, what are the factors based on is the risk stratification, initial risk stratification is carried out.
Sir,
The
initial,
standard risk patient and the high risk patient based on which parameters?
sir, mainly, firstly, the age of the patient, the initial total TLC, then any presence of any bulky disease, or if in case of boys, if there is testicular involvement, mainly these factors are taken into consideration for risk stratification. Like for this,
Testicular involvement, does it come? The
yes,
one
sir.
is the age, 1 to 10 years, another is the WBC count, more than
WBC
50,000.
count more than 50,000, less than 50,000. If
Yeah.
there is any
Purvali,
yes, sir.
just I want to tell one point that is most prognostically significant is the first dose response. If the reduction of the count is dramatically after giving the first dose, that is the most prognostically good, along with other factors you have told. First dose response.
Pritam will highlight, but the one is the age, 1 to 10 years, second is the WBC less than 50,000, and third is the immunophenotype. If it is BALL, then the prognosis is good as compared to TALL. And the fourth is the cytogenetic study, the certain cytogenetics like hyperploidy, as well as the certain translocation, they carry good prognosis. And another is the rapidity, as Kostubs has said, rapidity of response to therapy. The day 8 blood cell count, absolute blood cell count, less than 1000 per cubic millimeter in the peripheral blood following prednisolone therapy and only 1 dose of vincristine. The rapidity of response, this indicates good prognosis. So these are the 5 or 6 parameters based on which the risk stratification can be made.
Hyperdiploidy also, hyperdiploidy.
Hyperdiploidy. So comments from Dr. Pritam, the testicular involvement and the other things, they usually do not come in the risk stratification.
No, sir. No, sir, they do come. So,
Yes,
involvement of the sanctuary sites like central nervous system involvement and testicular involvement are considered to be high risk features. So, in boys, if there is testicular involvement, we take it as intermediate risk, and any CNS involvement is always taken as high risk disease. And the last one parameter, which is very prognostically important and is taken in risk stratification, is something called MRD, minimal residual disease assessment, that we do after the end of induction. So in today's date, that is the probably single most important prognostic parameter for childhood ALL. Thank you.
So, Kaustubh, we can move on the second.
Yes, second case. Just 1 minute left.
No, nothing. We don't need to be on the dot for the starting the second case. Now, Dr. Shubham Bhattacharya is there. He is the mentor of the case. Now, Shubham, please introduce Kaustubh, Dr. Kaustubh Ghosh to start the case presentation. Over to Shubham.
Thank you, sir. Dr. Kaustubh is a sincere postgraduate trainee in our Department of Hematology, NRS Medical College. He is currently in the second year of his course, and he will present a very interesting case of pediatric hematology. Now, he has done his MD in medicine, followed by doing DM in clinical hematology.
Thank you, sir. And very good evening, respected teachers. Today I'm going to present a case. coming to the history, a 3-year-old male presented with the complaints of on and off fever for the last 2 months and right eye proptosis for the last 1 month. The fever was not associated with any weight loss, night sweats, any cough, a rash, joint pain, or any abdominal pain, or any swelling in any part of the body. And after that, after a span of 1 month, uh, uh, he developed gradually progressive swelling of the right eye, and he presented to us with the right eye proptosis. On examination, the patient was febrile. In the general examination, moderate pallor was present, and petechial spots were present over the bilateral upper limb. There was no cyanosis, clubbing, lymphadenopathy, or any other significant symptoms. In the systemic examination, mild splenomegaly was present, and the other system examination revealed no significant abnormality. So coming to the differentials based upon the history and clinical examination of fever, along with bleeding signs, along with proptosis, along with mild splenomegaly. So the first possibility, it can be acute leukemia. To be more specific, it can be acute myeloid leukemia presenting as chloroma. It can be any myeloproliferative neoplasm such as chronic myeloid leukemia or juvenile myelomonocytic leukemia. It can be a case of retinoblastoma. Sorry for the problem. The fourth differential can be a case of rhabdomyosarcoma. A fifth differential can be a case of orbital lymphoma. And the sixth differentiation, it can be a case of Langerhans cell histiocytosis. After that, we proceeded to the investigation. So, sir, should I continue with the investigations?
Okay. Hello, Dr. Kostov.
Yes, sir.
Going back to the clinical portion, because
yes,
the
sir.
organizer told me that mainly this will be clinical exercise.
Okay, sir.
The 3-year-old male child, the presenting with fever and proptosis of 1 month duration.
Yes, sir.
Commonly, the common possibilities in our pediatric ward, we always keep one is the acute leukemia AML.
Yes, sir.
Another, of course, is the retinoblastoma, the small child.
Yes, sir.
And the other possibilities, right? Rhabdomyosarcoma, all those other things can be found sometimes, but LCH we sometimes keep in the differential diagnosis.
Yes, sir.
This child showing bilateral proptosis more in the right eye as compared to the left eye.
Yes, sir.
So these are the possibilities we keep usually. The examination showing splenomegaly, also no hepatomegaly. There is no generalized lymphadenopathy. Pallor is there. And what about bleeding manifestation?
Sir, in the history, there was no bleeding manifestation, but in the general examination, so there were petechial spots present over the bilateral upper limb.
Bilateral upper limb. Bilateral.
Yes, sir.
So petech is there. Any chloroma in the around the forehead region and over this skull, this scalp? Chloroma, evidence of bony swelling?
No, sir. There was no evidence of sir, any bony swelling or any lymphadenopathy, sir, in any other part of the body. Only swelling was, sir, it was, sir, in the right eye proptosis. This was evident.
Bony tenderness was there or not? Any bony pain?
No, sir. Sir, there was no bony tenderness and there was no bony pains. So history of any bony pains in the chief complaints.
Right. For the duration 1, 2 months and 1 month. Right?
Yes, sir.
Other eye was normal or there was mild proptosis?
There was mild proptosis of the left eye, sir, present.
And pallor, moderate pallor was there.
Yes, a moderate amount of pallor was present, along with some mild splenomegaly. So there was no hepatomegaly was present.
Yes.
Actually, two possibilities we in the pediatric ward, if we get this sort of cases, we put either acute myelogenous leukemia AML or LCH as the possible, and other than the retinoblastoma. So these
The
are the
age is AML is I think sadly occurs in a higher age. Is a age of ALL.
Yes, sir.
now what parts the ALL can sometimes ALL can also have this sort of presentation. So
Yes.
the Shubham is Dr. Shubham is there, Shubham as well as Pritam is there. So this sort of presentation with ALL, is it common because this is the age for ALL?
So it is very uncommon in ALL because this proptosis per se is, I have not seen any patients of ALL like this presentation at least.
Yes, I have also not seen. One atypical feature is that
Dr.
age.
Pritam, what is your opinion?
Yes, sir. I have seen ALL presenting with proptosis, but not up to this extent. This looks like to be an extensive degree of proptosis. Not like that, but yes, I have seen ALL with proptosis. I will like to make a comment. In such a child with proptosis, bone pain, bleeding manifestation, I would also consider a possibility of metastatic neuroblastoma in young child. They do present with proptosis, bone pain, and very much mimicking like acute leukemia. But having a splenomegaly will be obviously a clinical oddity for that.
Neuroblastoma, the periorbital ecchymosis and proptosis, which one? The both can be found, Dr. Pritam?
Neuroblastoma,
The
more common opsoclonus, opsoclonus, and
The-
also raccoon sign. Raccoon
The-
sign.
raccoon eye periorbital ecchymosis.
Ecchymosis and
The textbook says the
opsoclonus.
periorbital ecchymosis, and how far the proptosis is common? I
It
do
is
not
quite
have
common,
any-
sir.
Quite
It is quite common, but yes, as you say, most of the time it will be associated with periorbital ecchymosis, giving a raccoon-like appearance. But proptosis is pretty common in metastatic neuroblastoma.
Yes.
Okay. Okay, thanks.
Next, move on.
Okay, carry on. Gustav, carry on.
Yes, sir. So after that, we first done the CBC with PS. In the CBC with PS, the total leukocyte count was on the higher side. It was 29,200, and there was left shift present. There was predominance of the myelocyte and metamyelocyte together constituting about 40%, and neutrophil 35%, lymphocyte 17%, monocyte 6%, and eosinophil 2%. Along with that, anemia and thrombocytopenia was present. In the peripheral smear, there was anisocytosis and the RBC predominantly being normocytic normochromic, along with nucleated red blood cell was present. It was 10 NRBC for 100 WBC. So overall, it was a leukoerythroblastic blood picture. The routine biochemical test along with the TLS marker were within normal limit, except for the raised LDH, which was 1456. Shall I proceed, sir?
Yes, now one
Yes.
question. Why NRBC is raised in this situation? Because of the stress in the bone marrow.
Yes, sir. Sir, any bone marrow infiltrative sir cause, it can lead to leukoerythroblastic blood picture. It can be seen, sir, both in acute leukemias, also in some myeloproliferative neoplasm. But acute leukemia, sir, without any blast and with high TLC, sir, it is unlikely. So this type of CBC with PS in the setting with the clinical and the examination, it is more in favor of some myeloproliferative neoplasm.
Yes.
Myeloproliferative neoplasm.
And myeloid cells is involved.
Yes, sir. There is predominance of myelocyte and metamyelocytes of 40%. And there are, sir, no blasts, sir, in the peripheral smear. If it had been, sir, acute leukemia, with such, sir, high TLC, sir, there would have been surely, sir, blast.
Blast. So can we, this bone marrow picture, or the not the bone marrow, the peripheral blood picture, can we guess that there could be myelodysplasia?
Sir, in myelodysplasia, sir, there is, so this type of picture, sir, is usually, sir, not sir, seen, sir, the leukoerythroblastic blood picture. Sir, in this possibility, sir, with myelocyte, metamyelocyte, and NRBC is predominant, it is more in favor of some myeloproliferative neoplasm. Any some myelodysplasia
Bone marrow infiltration. It indicates bone marrow infiltration.
Yes, sir. Yes, sir.
Leukoerythroblastic blood picture.
Yes, sir.
Also, is it possible to have a leukocyte reaction? Because in leukocyte reaction, also myelocyte may go high without any blast.
Sir, it can be a possibility, sir, but in our setting, sir, in my, sir, experience, or whatever, sir, cases I have seen, sir, any case of acute leukemia, sir, with high TLC, sir, getting no blast is, sir, very rare.
The chances are high here,
Yes,
leukemia, but possibilities.
Yes, sir, it can be, sir, a possibility.
Okay.
Next, what you have done?
So looking at the CBC and PS and suspecting the myeloproliferative neoplasm, after that we planned bone marrow aspiration along with biopsy and the cytogenetics. In the bone marrow aspiration also, there was increased myelopoiesis. As in the figure we can see, there is predominance of the myelocytes and the metamyelocytes with the reduction of the erythroid lineage, the lymphoid lineage, and the megakaryocytes. So our possibility was confirmed, and the aspiration report along with the CBC, it was suggestive of myeloproliferative neoplasm. So as I mentioned, there can be two possibilities, CML or JMML. So first, we tried to rule out the common one, that is the chronic myeloid leukemia. So first we did the cytogenetics from the bone marrow sample, and cytogenetics came as trisomy 8. We also sent the fish for BCR-ABL, but it came negative. So our possibility of acute leukemia was ruled out by the CBC and the bone marrow, and our possibility of CML as a MPN, it was ruled out by the cytogenetics and for fish for BCR-ABL study. Next thing that we went to proceed is the biopsy of the muscle mass in the right eye. If we could have got any blasts in the biopsy, then it would be suggestive of scleroma, and it is an indication for treatment, and it would be acute myeloid leukemia if we get any myeloblast on the biopsy. But to our surprise, in the HPE of the right eye muscle biopsy, it was only inflammatory changes. There was no malignant cells seen. So the possibility of AML presenting as scleroma and CML was ruled out by the following investigations.
Wow. In the bone marrow, there was no myeloblast?
No, sir, there was no blast.
No blast? No, within normal range.
It was a non-significant issue.
Yeah.
It was a 3% blast was there, but it was a non-significant.
In trisomy 8 was there?
Yes, sir. Another point, sir, against the CML was that, sir, there was a no...
BCR-ABL negative.
Yes, BCR-ABL negative, and there was a no, sir, basophilia, sir, in the bone marrow aspiration, also in the CBC, so there was no basophilia, which is also a strong point against the CML.
Dr. Kostov, when the bone marrow aspiration is not showing any presence of blast cell, the muscle biopsy from the eye, will it help to establish AML?
Yes, sir, definitely, sir.
In absence of blast cell in the bone marrow?
Yes, sir. Yes, sir. There can be, sir, extramedullary blast proliferation.
Would it be localized with skipping the bone marrow, the blast cells?
Yes, sir. It can be, sir, a possibility, sir. We have I have seen, sir, around 4 to 5 cases, sir, of AML, which have presented, sir, as an extramedullary blast with absolutely normal, sir, CBC and bone marrow findings. And on confirmation of the tissue biopsy, there was a myeloblast, which was, sir, MPO, sir, positive.
Yes. Yeah. The trisomy 8 has relation with JML. Juvenile myelomonocytic leukemia trisomy 8.
Sir, actually, trisomy 8 is linked to some myeloid malignancies. It is more commonly seen in AML, and in AML it is as a bad prognostic marker. Trisomy 8, sir, it is normally resistant to the conventional chemotherapy that we give in AML, that is the cytarabine with daunorubicin induction, and presence of trisomy 8 in AML, it signifies a poor prognosis and a lower survival rate.
Now, there is no blast cell in the muscle also. Then what is thought?
Sir, so based on the clinical findings and the examination, sir, we got, we are left. So the third possibility we thought of JMML. Sir, it is where it is very rare, only 2 to 3% of the myeloid malignancies. So first ruling out the common one, that is first the acute leukemia, followed by CML. So after that, so we were left with JMML.
CML is common in pediatric age group, CML.
So CML is also not common in pediatric age groups, and JMML is more uncommon. So first we tried to rule out CML, and when there was no feature suggestive, so third possibility, sir, we went for the confirmatory diagnosis for JML.
Then what in JML platelets are very high, I think. Platelet count.
Sir, in AML, sir, in JMML there is anemia along with thrombocytopenia.
And also lymphadenopathy. Skin changes, yes, all are common in JMML.
Yes, sir. Yes, sir. In JMML, skin changes is common. There can be lymphadenopathy, and the GI and the respiratory system is also involved. It can present as a chronic diarrhea, and or with recurrent respiratory infections. So these are the other clinical findings, which can be seen in JMML, but it was not present in our case.
Then,
so moving forward. So after that, the NGS myeloid.
Okay, Costa. The clinical picture is suggestive of because acute leukemia is common in pediatric age group as compared to JMML. The clinical picture is suggestive of acute leukemia. The bone marrow is showing the presence of premature WBC series.
Yes, sir.
And the cytogenetic showing trisomy 8. So can you, in this case, as the AML is more common as compared to JMML, acute myelogenous leukemia is more common as compared to JMML. So is there any indication of immunophenotyping in the bone marrow sample to look for the AML?
Sir, immunophenotyping is only done if there is present of significance or blast number. Sir, if it is not present, so then it is not an indication on immunotyping. And even if the blast number is not that much, but there are recurrent genetic abnormality, then also we can stamp it, sir, as AML. Such as RUNX1, sir, 821 translocation, or sir, PML RARA, sir, 1517 translocation. In all these cases, we can directly stamp it as AML without submitting the blast.
1517 the promyelocytic leukemia.
Yes, sir.
APML.
Yes, sir.
That presentation is different. Presentation is different.
Yes, sir, but
DIC-like picture.
Yes, sir. Sir, but trisomy 8 is not specific for AML. Sir, it can be seen in myeloid malignancies. Yes. And for AML, yes, sir. And according to the latest WHO classification, so there are certain recurrent genetic abnormalities based on which we can directly stamp it as AML. So, sir, trisomy 8 is not significant. So that is why, sir, we can't directly go for immunophenotyping, sir.
Okay.
Then ultimately, what happened?
So ultimately, sir, we did a NGS or myeloid panel, and in that, pathogenic and a rash
Yes, yes,
mutation. But yes, sir. So, sir, finally, sir, our diagnosis, sir, we confirmed as sir, GMML. Sorry, sir, no, there is some problem.
Okay, no.
So our final diagnosis is JMML. And now coming to the WHO classification for JMML, at least all the four clinical and the hematological features should be fulfilled. And in our case, all the four were fulfilled. The peripheral blood monocyte count more than 1,000. In our case, the
your
total
screen in the slide from Pusta. You make your screen in the slide from. It's
yes, sir.
like from the small.
I've
So
done that. The slide form I've done.
okay.
Is it visible, sir?
Visible. Okay. Visible but small. The letters are very small. Okay.
Yes, sir.
Criteria. WHO classification.
Yeah. So coming to the WHO classification, at first it is the clinical and the hematological features. All four are mandatory. The first one was confirmed as in our case there was peripheral blood monocytosis. The total count was 29,000, out of which 6% was monocyte, as I mentioned. So the absolute lymphocyte, absolute monocyte count, it will be around 1,500. And the blast percentage in the peripheral blood and bone marrow was less than 20%. Along with that, splenomegaly was present, and there was absent of the Philadelphia chromosome. And then coming to the genetic studies, only one finding is sufficient. Either there can be somatic mutation in the PTPN11, KRAS or NRAS, as in our case, NRAS was present, or a clinical diagnosis of a neurofibromatosis 1 or NF1 mutation, or any germ9 CBL mutation, or loss of the heterozygosity of the CBL gene. And if there are no genetic features present, then based on the clinical and the hematological features, any one of the following criteria should be fulfilled. That is the monosomy 7 or any other chromosomal abnormality, or at least two of the following. That is increased fetal hemoglobin for age, and then myeloid or erythroid precursors on the peripheral blood smear, the GM-CSF hypersensitivity in the colony assay, or hyperphosphorylation of the STAT5B. Shall I proceed, sir, to the approach part?
Okay, do.
Yes, yes.
So it's fulfilling the essential criteria as well as one of
Yes,
the
sir.
second criteria.
Genetic criteria.
Genetic criteria.
Yes, sir.
So by that
Yes,
we
sir.
can say that this is JMML.
Yes, sir. But sir, we presented this case because sir, till date there are very less sir ocular involvement cases of sir JMML. Only 3 to 4 cases in the literature, sir, has described the ocular involvement in JMML. It is very rare, but it can be sir present. So after ruling out the common possibilities, we must keep this possibility in our mind. So first the clinical signs of the JMML, and then the molecular characterization. After that, we will confirm by the WHO criteria, as I mentioned. After that, if there is CBL gene mutation present, they are generally silent. So watch and wait is the policy. But if there are NF1, PTPN11, NRAS or KRAS mutation, then the HSCT is the treatment of choice, as it is a very aggressive disease with very low survival rate. If a HLA identical sibling is present, then we should directly proceed for the HSCT. And if not, we should start the search for any unrelated donor or any cord blood transplant. So in our case, there was no sibling, hence the HSCT could not be planned. Conservative management was planned, and among the drugs, only azacitidine, that is a hypomethylating agent, has shown to be of some benefit in patients of JMML. So injection azacitidine was started at the rate of 75 mg per meter square for day for 7 days, and the first cycle along with the TLS monitoring and the prophylaxis. But there was no response to azacitidine. The TLC persistently increased along with anemia and thrombocytopenia, although there was slight reduction in the orbital mass. After that, as there was no response to azacitidine, we went for the salvage chemotherapy protocol, that is the cytarabine, etoposide, and the vincristine. But as this is a very aggressive disease, we could not save the patient. The patient succumbed on day 28 of therapy due to the febrile neutropenia.
Okay, unfortunately, the child succumbed. Okay, the JMML
Prognosis is bad.
the
All
prognosis
AML
is bad.
prognosis is bad.
What about the mono? Do you see the JMML cases off and on? Because you are a yours is a referral center, and monosomy 7 is quite common. This is said.
Yes, sir. Yes, sir. Monosomy 7. Yes, sir. Sir, actually now I am, sir, in the second year, and in my, sir, 1.5 years, I have seen only, sir, 3 sir, JMML cases till now, and we could not, sir, survive any one of the patient. It is a very aggressive, sir, disease, very chemo resistant, and the survival rate is, sir, very low.
Yeah. As such, all AML prognostically bad in comparison to ALL.
But the presentation, just for the sake of the PGTs who are attending this CME, I mean this program, if we come across this sort of case, 2 years child with history of fever and proptosis, we usually give the differential diagnosis. AML is one. The second is, of course, the retinoblastoma, the rhabdomyosarcoma, the LCA. And as Dr. Pritam said, that the neuroblastoma can have this sort of presentation. So these are the 4-5 possibilities to be kept in the differential diagnosis. And all of us know that the JMML is based on the criteria-based diagnosis. And the management is very difficult and the prognosis is very bad. So all of us know. So from my point of view, I am giving thanks to the organizer, to the mentors, and to the all the participants. And Postap says something, and then over to organizer.
No,
Okay, Shubham, before I finish, Shubham.
Yeah, I think Shubham will give a comment, expert comment.
Shubham.
And also see that if there are any questions on chat box. Dr. Shubham, please.
Shubham.
Shubham is here.
No, Shubham has left, I think. So the experts, if you have any query, answers on the chat box, and please take the questions on the chat box if there's any, if any.
So, the Pritam Singh can take this thing, or I can take this question.
Yes, yes.
Yeah, I can see there is only one question that can umbilical stem cell help in treatment of JMML? So answer to that is yes, because eventually the definitive treatment for JMML is allogenic hematopoietic stem cell transplantation. So yeah, umbilical cord stem cell transplantation could be done for that purpose. However, unfortunately, most of the situations of JMML, what we do is just give palliative chemotherapy. Typically 6-mercaptopurine, cytarabine, or azacitidine-based chemo, as was highlighted in this case, is being used. But most of the cases, the prognosis is very poor, except for a few situations when they have some underlying syndromes in which there can happen spontaneous resolution of JMML. Otherwise, JMML carry a poor prognosis in general. Thank you.
I've got one question.
One question to Costa. Is in Down syndrome, can you get JML? Because in Down syndrome it's very much prone to develop leukemia. So is there any chance of having JML in Down syndrome?
So JMML, sir, it is commonly associated with Noonan sir syndrome.
Yes, Noonan is common, but Down?
No, sir, Down syndrome, sir. Actually, sir, I don't have ideas, sir, but I think, sir, the cases that we all see, sir, we have seen, sir, AML and AML and ALL, sir, cases associated with sir Down syndrome, sir. But JMML, sir, I haven't, sir, heard of.
Yes.
Neurofibromatosis also can develop.
Neurofibromatosis is association.
Yes, sir.
Neurofibromatosis also.
Because in
I have one query. Dr. Pitam or Dr. Kosta, anyone can take. What is the relation of the trisomy 8 over here? You got my trisomy 8?
Ma'am, trisomy 8 is linked to my myeloid malignancies. And since GMML is a malignancy affecting the myeloid and monocytic lineage, it is rare, but it can be seen. But trisomy 8, it is most commonly seen in acute myeloid leukemia.
I've got one question. I've got one question, and please clarify either the expert or the mentor. So down the line, 15 years back, it was said that the umbilical cord, just the preservation is of no use, because the stem cells from the umbilical cord, if it is preserved, will come to no help. Now, Dr. Pritam is saying that it can be of help. So what is the recent stand of this umbilical stem cell preservation?
Yes, sir, I completely agree. There is no scientific rationale of routine preservation of umbilical cord banking that most of the private setups now often encourage the expecting parents. So there is no scientifically approved benefit for that. And I think even Indian Academy of Pediatrics has a standpoint on this, that there is no scientific benefit. Now, when I say yes, umbilical cord stem cell transplantation can be done, it just means that this condition is curable by any form of transplantation, including if the stem cell source is from the umbilical cord. But it doesn't mean that we should routinely endorse for going for umbilical cord banking. That is not scientific. It is not what to say, logically correct.
Thank you.
Very good cases. Both are well worked out and good cases.
I think now we can end the session. Is it,
Yes.
Dr. Shapur?
Thank you, everybody, and thank you to our expert, Professor Supratim Datta and Professor Kaustubh Naik. Thanks to Dr. Pritam Singhara and obviously Shubham Bhattacharya. Thanks to the presenter, Dr. Pulvali Ghosh and Dr. Kaustubh Ghosh for these nice presentations. So our next Sandhya Pathshala will be on which system? Kalpana Madam.
Okay. It was a wonderful presentation by Dr. Kaustubh and Dr. Pulvali. It was a wonderful presentation and a very nice discussion. I think the attendance has gained many experiences and many knowledge from the experts and the presenters and the mentors too. The mentors are also very excellent. And similarly, we'll have we'll have many case presentations in the subsequent months till 12 months. So already we have 4 cases. This is the 5th month. And according to the demand, if you have any special case presentation, I'm requesting the attendees and the participants, if you have any special case presentation you need, please let us know. We'll have that type of case presentation and we'll have good experts and mentors too. So in the next Sandhya Pathshala will be again the last Sunday, 8 to 10 p.m. Till then, I think I must say thank you to the experts, both Dr. Kaustubh Naik and Dr. Supratim Datta. Thank you, the mentors, Dr. Shubham and Dr. Pritam. And of course, thank you to our scientific chairperson, Dr. Shapur. And this is time to say good night and goodbye to all.
Good night, everybody.
Thank you, madam. I'm leaving.